Here's a listing of the common gastrointestinal complaints that patients have. Make sure you go through each and understand the meaning of the term, but more importantly, or as important, make sure you also ask yourself, what is the source of the pathophysiology that can lead to these complaints? Here are the varieties of diagnoses that we'll review as a part of this portion of the course. GERD is gastroesophageal reflux disease, also known as heartburn. Make sure you go through each of these and have an understanding of the types of patients that develop these diseases or syndromes, how they present, and the source of their pathophysiology. Here's a visual representation of the common signs and symptoms of GI dysfunction. The symptom of anorexia is distinct from the diagnosis of anorexia nervosa. The former is a symptom, a lack of desire to eat despite physiologic stimuli that would normally produce hunger. The latter is a psychiatric diagnosis. So in this portion of the course, we're talking about anorexia as a symptom where the patient loses their appetite. There are a variety of things that can cause this that are listed on the slide here for you. Make sure that you go through each, that you understand it, and that you're able to connect the pathophysiology to the symptom of anorexia. Nausea and vomiting is another very common complaint. Nausea is the feeling that you're going to vomit, and vomiting is the forceful expulsion of contents of the stomach. You can see there are a number of internal causes that are listed on the left that can lead to nausea and vomiting, and a number of external causes on the right. Make sure you go through each of these causes and develop an understanding of the pathophysiology of the cause of the nausea and vomiting, that you connect it to the underlying disease, and that you have an understanding of the types of patients that develop these issues. Patients who feel nauseated don't want to eat. Constipation is a very common patient complaint. It's defined as infrequent or difficult defecation. As a primary condition, it can be due to functional constipation, slow transit, or pelvic floor dysfunction or outlet dysfunction. All of these lead to primary constipation. Secondary constipation is where the patient develops constipation that's secondary to medication use or to another disease. This is a slide that reviews how habits and stress can cause constipation, and you should go through each of these and make sure you understand the pathophysiology behind it. As I mentioned, secondary constipation is secondary to another process, another disease, or to medication use, which is very common. It's a secondary condition, meaning it's caused by a primary condition. Many factors can be involved, such as a low-fiber diet, use of medications that slow transit time or decrease contractions of the GI tract, various medical disorders, aging. The manifestations are basically the same as primary constipation, and part of the approach is to manage the underlying disease, but also to apply therapies that work with primary constipation. This table lists for you the common triggers of constipation in adults. Again, be familiar with all of these and how they lead to the pathophysiology that ends up with constipation. One of the biggest culprits in the American diet is low-fiber foods. Diarrhea is the presence of loose or watery stools. It can be acute or chronic. It can be large volume or small volume. The way the diarrhea is described is often leads to important clues about the source of the diarrhea. When we describe the mechanisms of diarrhea, we use the 4 categories that are listed here on the slide: osmotic, secretory, motility, and inflammatory. With all these, the underlying pathology leads to loose stools that is often the result of incomplete absorption. In osmotic diarrhea, a non-absorbable osmotically active substance is ingested. So oftentimes laxatives use this to create loose stools. So if you place a substance in the GI tract that cannot be absorbed but is osmotically active, it's going to pull water into the lumen of the GI tract. Again, many laxatives operate this way. In secretory diarrhea, electrolyte absorption is impaired, and most cases of acute and chronic diarrhea are due to this, but especially acute. You can see it with bacterial toxins, specific substances that are listed for you, or it can occur as a part of a medical problem. So the chronic conditions of chronic diarrhea tend to be more related to underlying chronic medical illness, whereas the acute tend to be acquired. These are the four major types of diarrhea that are labeled by their pathophysiology. So go through each of these, understand how they produce diarrhea, and understand how the examples given cause that type of diarrhea. This slide breaks up acute versus chronic. It presents a little bit of a different approach, but still similar to the one I just described for you. But you can see that acute diarrhea is less than 2 weeks. It may result from emotional stress, food intolerance, substances that are ingested, or medications, or most commonly it's from an infectious agent. It leads to an inflammatory or bloody diarrhea, or a non-inflammatory diarrhea, and that's helpful in deciding what's the cause. The third possibility is food poisoning. With chronic diarrhea, it's diarrhea that lasts for more than 2 weeks, and in this slide there are actually 6 categories listed. 4 of them you've already seen. The other 2 that have been added are related usually to chronic underlying disease. Diarrhea, both acute and chronic, can lead to dehydration, electrolyte imbalances, and weight loss. Here's a bit of comic relief for you.